come to the symposium. The symposium is named as How I Approach to Clinical Dilemmas. And our first speaker is Dr. Namal Veerasurya. He's currently a consultant orthogeriatric medicine and healthcare of old people at Nottingham University Hospital, UK. He has specially led mortality reviews, and his special interest is on osteoporosis and falls. Let me, yes, he's online now, so let's listen to his talk on.
Greetings to everyone. I'd like to thank SimCon for inviting me to share some of my thoughts and practices with you on transient loss of consciousness. It is brief, spontaneous loss of consciousness with complete recovery and without any residual neurological deficit. Understandably, it induces anxiety in those who experience it either as a sufferer or a witness, and concern among healthcare professionals. I like to hear stories rather than bare facts, so I thought I'd do the same for you in this regard. So the story was of a person called Mr. B who was referred by his general practitioner asking for assessment and advice. So he was 70 years old, described as having recurrent collapses for the preceding 3 months, the last of which was a week ago when he had been having breakfast with his partner and he had collapsed into his cornflakes. So my thoughts were that the story is rather brief and I'd like more information, and I was hoping that he would come with his partner so that I could get a detailed history about how he was, what happened before and after the event. And if he hadn't brought her, I would have asked his permission to speak to her over the telephone and got this information. So the GP had kindly listed medication and the medical history. Looking at the past medical record, I could see that he had some degree of vascular disease with hypertension and TIA, and he was on medication that could bring down his blood pressure, which was a combination of amlodipine and benzodiazepine. And he was also on a drug that geriatricians dislike very much, which was a sedating anxiolytic, temazepam. And I was thinking, was this man falling asleep onto his cornflakes? So I move on to the detective mode. For instance, I needed to know how many of these episodes had happened. What did he look like during the episode, before the episode, after the episode? When did the collapses happen? And where did they take place? Because all these would aid and be key to identifying what the problem is and to manage this condition. Mr. B walks in looking perfectly healthy, sits down and says, "Doc, there's nothing wrong with me. I feel a fraud coming here." And there she is, his partner, sits down, shakes her head, bursting to come out with the story. So I tell him, "Your GP thinks that you're collapsing. So I'll first listen to your story and then I'll ask your wife to describe her story." But it doesn't work like that in real life. So his partner starts the story. "We were having breakfast I was reading to him about a possible holiday cruise. Said that it looked like a good deal. And then he just fell forward into his cornflakes. I felt annoyed that he was acting the fool, but then he was out. He was pale, and he was out for a few seconds. Then he shook his head, cleared up the cornflakes, and asked, "What's the matter?" as if nothing had happened. So he says that he was at the breakfast table, he was seated, and a warm sensation crept up from his stomach to the chest and to the head. The next thing he knew was that he found himself with the head in the bowl of cornflakes. Other than feeling awkward, he felt fine. Then when asked whether he has had episodes where he had found himself fallen, he said that 3 weeks ago when he was walking back from shopping, he found himself on the ground. He didn't know how he got there, picked himself up and walked home. Then about 3 months ago, he was watching television. He thought of getting up to go to the toilet, and the next thing he was on the floor, got up, walked to the toilet and went to bed. He had obvious transient loss of consciousness. Now, transient loss of consciousness could be broadly due to three underlying problems. It could be due to global brief hypoperfusion of the brain, which we call syncope. Or it could be due to a primary electrical problem of the brain, which we could call epilepsy. Or it could be a problem with the mind, which we call psychogenic pseudosyncope. Mr. B's story did not suggest epilepsy. There was no suggestion of a epileptic attack, such as prolonged limb jerking, confusion after the event. There was no description of a typical finding of epilepsy, such as tongue biting. His behavior and mental state before and after the event appeared to be quite normal. It also did not suggest a problem of the mind. The description that his wife gave was that it was quite brief. It didn't go on for more than a minute. There was no multiple high frequency of episodes. And he wasn't really seeking medical attention, he wanted to avoid it if at all possible. Out of the different causes of syncope, the story that was given suggested that it could be a rhythm problem of the heart. It could be left ventricular tract obstruction, a structural problem of the heart, but what was against that was that in between these episodes, he did not describe any physical dysfunction, such as breathlessness on exertion, chest pain on exertion, or easy fatigability. It could be orthostatic hypotension, but the worrying situation was that the last episode of collapse happened when he was seated, even though the other two happened when he was standing. It wasn't situational syncope because he wasn't straining at micturition or exposed to high emotional situation. It didn't also sound like carotid sinus hypersensitivity. For example, the classic patient that I have encountered who had carotid sinus hypersensitivity was a gentleman who had repeated episodes of collapse in his local church when he was looking up and sideways listening to the sermon in his Sunday best. Next step was to do a targeted but thorough examination of the relevant system. we needed to look for postural hypotension or orthostatic hypotension. He needed to lie down for 5 minutes supine, at which point the supine blood pressure was tested. Then with the cuff on, he would stand and the blood pressure was checked at 1 minute, 2 minutes and at 3 minutes of standing. Looking for symptoms with drop in the blood pressure of 20 or more of systolic blood pressure or 10 or more of diastolic blood pressure. If he had manifested evidence of orthostatic hypotension, obviously the antihypertensives would have been reviewed and reduced or stopped. The lifestyle measures of avoiding abruptly standing up, avoiding long periods of standing up, drinking plenty of liquids, and physical measures such as compression stockings could have been considered. Sometimes we need to add medication to increase the blood pressure, and this could be the alpha-adrenergic drug, midodrine, which increases the vascular tone, thereby increasing the blood pressure and reducing the drop in the blood pressure when standing, or the mineralocorticoid fludrocortisone. The unwanted side effect of both of these drugs is that they can cause supine hypertension. So generally, midodrine is avoided after 6 p.m. to reduce the risk of supine hypertension during the night. If fludrocortisone was started in a patient, one would need to monitor the electrolytes because it can cause hypokalemia, disturbance of sodium, as well as problems with fluid retention such as ankle edema. So these drugs need to be used judiciously and with monitoring, with the risks and benefits balanced. Mr. B had no postural hypotension. His heart rate was 94, it was regular. There was a systolic murmur at the apex, there was no radiation. The neurological examination was normal. Resting ECG is part of the routine assessment of this type of patient, and his resting ECG was not normal. It was somewhat similar to this, showing a right bundle branch block pattern with an axis to the left, even though in sinus rhythm. He had some red flag features. He had a cardiac murmur and he had an abnormal ECG. There was no description of family history of sudden cardiac death. As I mentioned before, there was no breathlessness on exertion, and there were no clinical signs of heart failure on examination. But he was over the age of 65 and he had disc collapses, he had a cardiac murmur and an abnormal ECG. So we needed to investigate further relatively quickly. I needed to monitor his cardiac rhythm now. The options that were open were either a Holter monitor where the heart could be monitored for 24 to 48 hours. It could be an external event recorder where the heart rhythm can be monitored up to 5 weeks, or an implantable loop recorder where the monitoring can take place even up to 3 years' time. The device that one could request for is generally decided by how frequent the episodes of transient loss of consciousness takes place, so that the device would capture this event. Now if it's a 24-hour to 48-hour monitor, if the events happen about every 4 weeks or so, is unlikely to capture the abnormal rhythm, and therefore would require a longer term cardiac monitor. In his case, the cardiologist first offered an external event recorder, and While the investigations were taking place, it was made very clear to Mr. B that he should not be driving. It is not a pleasant thing to tell somebody to avoid driving when they're used to driving, placing significant restrictions sometimes on lifestyle. But it's a necessity for their safety as well as the safety of other road users, and it's a legal requirement in the UK. He also underwent an echocardiogram which was normal. There was no left ventricular outflow tract obstruction. The event recorder was on for 5 weeks, but he did not have an episode of loss of consciousness. But 2 weeks after the event recorder was taken off, once again he lost consciousness while he was seated. So he was referred to cardiology for an implantable event recorder, and subsequently went on to have a permanent pacemaker when it was detected that he had a 2:1 block identified on the loop recorder. So that was the story of Mr. B, which had a happy ending, I should say. Head-up tilt table testing is a means that we use not infrequently to identify cause of syncope or loss of consciousness when it is not quite clear from the history as to what is causing it. So this is a couch that can be electronically tilted from -30 to the horizontal up to a vertical position. The patient's heart rate and blood pressure can be monitored and is monitored from beat to beat, while continuous ECG monitoring also takes place during the procedure. A brief description of what happens during the tilt table test. The person is lying down horizontally on the couch. The heart rate and the blood pressure are monitored beat to beat. So after 5 minutes of lying down, they have the carotid sinus massage performed, one side at a time, and we check for evidence of carotid sinus hypersensitivity, manifesting as a significant drop in blood pressure or the heart rate, and reproducing the symptoms of presyncope or syncope. Then the tilt table is tilted up to 70 degrees from the horizontal, at which point we might be able to identify postural hypotension. And after being upright at 70 degrees for about 5 minutes, we once again do the carotid sinus massage, one side at a time, looking for evidence of carotid sinus hypersensitivity. 15 minutes in that position. If there is no syncope identified or presyncope, GTN provocation with 400 micrograms sublingually is administered. The heart rate and the blood pressure continue to be monitored, and the test is terminated if syncope occurs or if it does not take place up to 20 minutes after the GTN provocation. So this is a pattern of heart rate and blood pressure of somebody who has a normal test result where the heart rate and blood pressure climbs up slightly on the upright position and then goes down slightly once tilted down. This shows somebody who has got reflex syncope. It depicts both cardioinhibitory type as well as vasodepressive type. So in the cardioinhibitory type, the heart rate goes down significantly, and with it the blood pressure drops as a result, and there is syncope. That type of person is usually referred to cardiology for consideration of a pacemaker. In the vasodepressive type, the heart rate does not go down, but the blood pressure goes down with resultant syncope, and such people are advised on lifestyle measures such as those who have postural hypotension. Here you can see somebody who's got postural hypotension. The classical type as well as the delayed type. In the classical type, um, soon after being tilted upright, the blood pressure starts dropping, and within the first 3 to 5 minutes, it goes down significantly, and there can be syncope. With correction of that, when the tilt table is tilted down to the horizontal or to minus 30 from the horizontal. In the delayed type of postural hypotension, the blood pressure does not drop significantly within the first 5 minutes, but drops later on, resulting in syncope. In the postural tachycardia syndrome, there is a sustained increase in the heart rate when the person is tilted up. It goes up beyond 30 beats per minute over the period of at least 10 minutes of being tilted up. And these patients can manifest as dizziness, sometimes pre-syncope or even syncope. Someone who has got psychogenic pseudosyncope, the person can manifest as having a head drop with closed eyes after being tilted up for some time, but their heart rate and the blood pressure do not show any abnormality to account for this. And one could identify that they have not truly lost consciousness either. So in summary, transient loss of consciousness is common. The history is key to identify the underlying cause. Think of the heart, the brain, or the mind as the primary underlying cause of the transient loss of consciousness. Remember the red flags for potential life-threatening causes. And do not forget about advice on driving. Thank you so much for listening, and I hope it will be of.
Thank you very much for that very interesting talk, Dr. Peter Surya. Hopefully you will be with us online towards the end to answer any possible questions. And I would like to invite our next speaker, Dr. Harshari Rajapaksha. She is a senior lecturer in the Faculty of Medicine, University of Luna, as well as a honorary psychiatrist of the Teaching Hospital of Kalapitiya. She will talk to us on multiple somatic symptoms and how to unravel the mystery. Over to you, Dr. Rajapaksha.
Good afternoon to all of you. Thank you very much for inviting me to share my thoughts with you all. I'm grateful for the President and the Council. And today we are going to look at multiple somatic symptoms. A shape we wouldn't see when wounded up tight in a ball, and how to unravel. So, what are multiple somatic symptoms? I think it's very familiar for all of you. They come to you again and again, or they might change the doctors, and they have so many symptoms. The slender man, actually, I took this picture because since they're going from doctor to doctor shopping, and also other traditional kind of treatment, they waste a lot of money on treatment and investigation, and they even don't have money for their day-to-day life. So this is the kind of patients we are talking about today. And at the end, we doctors also feel like, it cannot be real. It's all in their mind. And when it's in a kind of a tight ball, what happens? Usually the physicians or the clinicians also get frustrated. They are not the patients you like to see. Oh, this person again, right? And with their frequent complaints and dissatisfaction with the treatment we have offered. And also, the patients, on the other hand, they may perceive that, what offered was not good, and, the doctors, we don't take them seriously. So the both sides are there. So it's a frustration for the clinician or so-called difficult patients, and it's a frustration for the clinicians, the patients as well. And because of this, our smooth doctor-patient relationship will get affected. And further, it makes further confusing because of the way we name these somatic symptoms, because sometimes we just leave it as symptoms, right? Somatic symptoms or unexplained symptoms or dissociative symptoms, and sometimes we put them according to a particular speciality. If GI, it's irritable bowel; if rheumatology, it's fibromyalgia; neurology, non-epileptic seizure disorders. And also they have sometimes a particular medical diagnosis, a diabetes, hypertension, or some other bronchial asthma, and because of that we try to explain all these symptoms through that particular already diagnosed illness. And also as doctors, and these days with litigation and things are little more, we feel like whether we are missing something. So this cause anxiety in clinicians, in us. And also a lot of overlapping symptoms are there, especially anxiety symptoms. I want to say it's not an anxiety disorder, but anxiety symptoms are there in most of these patients. And also when these are prominent and when we see these things, we tend to think it is, and when the investigations are normal, we tend to, put them as psychiatric illnesses. But just being the absence of an organic illness does not necessarily point to a psychiatric diagnosis. But these are difficult patients, but we need to know them because they are common and they are associated with significant distress to the patient, society, and health cost. And for us, the secondary care physicians also, though because we don't have a good primary care facility in Sri Lanka, GP services, so they just come to you. I think you're the best people, the internal medicine physicians are the best people to handle these problems. And also, because if we don't know about their problems and issues, we might do some harm to them without our knowledge. And also in our system, we are not really trained to handle these people. So there are two types of multiple somatic symptoms. As this picture shows, it's a hedgehog in a ball, and when you turn it other way around, he'll put his head out and okay, it's a hedgehog. So the same way, the certain diseases, they come with multiple symptoms. I will take only one example, that is depression. Especially in Asian countries, they present with multiple somatic symptoms, especially burning sensation, devilla, angadhanama, හැමතැනම දෙවිල්ලයි, right? That kind of a thing more prominently than the mood symptoms, because as a nation, we are not very comfortable speaking about our psychological or emotional things. And they will complain of various aches and pains, and unless you look for it about the other things, anhedonia, persistent low mood, and lack of energy, and those things, unless you look for them, you might not diagnose. So if you are keen to know what this is, as the previous presenter Dr. Namal mentioned, you have to look for it, then you will see it. So these are in a way easy to diagnose at initial stages. Because like psychiatric diagnosis, I have listed few here, like depression, anxiety disorders, and psychological things like grief and adjustment reactions are very common these days due to COVID pandemic. They have not seen their loved ones, their funerals, right? So they will come to you with these multiple symptoms and certain personality issues. According to DSM classification, cluster C, anxious, avoidant, and obsessive kind of personalities. And the beliefs they have, soothsayers or fortune tellers or maybe the next door person. We have a habit of saying people like after many years or things, okay, you look beautiful last time, no, you have put up weight, and you know my grandmother also had the same thing, and you know we lost her last month, no. So this person will become a patient when you comment like this. Though it's a small thing for us, for that patient, there's a huge impact. And doctors also, the way we convey, the way we interpret, those things are very important because they might go home with some other message. And iatrogenic by our profession due to giving medications and procedures sometimes which are not necessary. And also the environment, the external environment like occupation or internal environment like certain life changes, menopausal symptoms, we may overlook. They also have multiple symptoms, but it is due to a particular cause. And also rare medical conditions like multiple sclerosis and can sometimes present with multiple somatic symptoms. This is the first type which I described earlier, and this is the second type. I took this example of a dung beetle's life cycle because the patients in that first category, if you really analyze and turn it out, you know what it is. But these people, from egg is different to larva to different from the next stages. The adult beetle is totally different from all these stages. So according to the stage we see this patient, the picture is different and we might not be able to identify each stage. There's some change occurring to the patient. That's why I mentioned, that we can't identify what it is when it is covered by this dung ball. I just give a case history of a patient so you can see how complicated this is. This is Mrs. M, 30 years, mother of a 3-year-old child, presented with episodic abdominal pain, frequent headaches, hemoptysis, and change of bowel habits for the past 2 years. And she was seen by a number of doctors. There were about 8 admissions, and though the sputum was pinkish, the investigations came normal, except for sinus tachycardia. And husband, he was a soldier, and he has stopped visiting her for past 2.5 months. And last year, her mother passed away, leaving the ancestral house, the home, to her younger brother. And there's a man who she has asked for some money, and this person is asking for sexual favors in return. So she works for a doctor, helping him bind the booklets for the patient's education. So she reads them, right? And astrologer has predicted that she has to undergo an abdominal surgery in near future. So you can see how complicated this person's issues are. So these are like ghosts. We can't see them at the outset. But if you keep an eye on, because not every patient has all these symptoms, some are straightforward pneumonia, the day-to-day things, those are easy. But this kind of patients, when they are patients who are going from doctor to doctor, seeing for the 12th or the 25th time, and also there must be some iatrogenic side effects. We usually miss them because we don't have time to go through everything the patient has undergone, the surgeries and investigations, and certain pain syndromes we have overlooked, which can be treatable. because sometimes we try to lump everything together. The headache there may be a reason behind headache, there may be a reason behind the backache, and certain psychosocial aspects. And also the patients and at times we clinicians, we both need quick fixes at times. So this leads to real issues. And unhealthy personality traits, the patients, usually these patients have. And the risk factors not addressed. And for the doctors, especially the young doctors, we have no particular proper kind of training to identify, treat, and a pathway to handle these patients. So those are there like goals in our lives. So because of that, when we see these patients, we feel little, uncomfortable handling these people. So when we assess this kind of a person, I think we all know these things, but still just focus on few things like ask them, what are your symptoms like, how they start, katandare kiyanna kiyala. Like sometimes because of time constraints, we don't let them speak, but kiyanna kohomada meka patan gatte, how did it start, tell me the story, right? And what makes it better or worse, and what brought you here today? I mean, this particular visit, you had this symptom for 2 years, but is there anything happening? Usually patients either pain is more, or they have a fear that something will happen to them, or there's something behind this particular visit, or somebody has told you are the best doctor to help this, or the neighbor got cured from your medicine. So try to find out why they came, right? And how your symptoms affect what you usually do, the functional impairment, and how upsetting. හිතට කොහොමද දැනෙන්නේ මේ ප්‍රශ්නත් එක්ක කොහොමද කරගන්නේ? How upset, the emotional component and the coping, because somehow the patient has coped up to 2 years or 3 years or whatever the duration. So what helped you, the supportive factors or the strength the patient is having. And then we can evaluate with an open mind, without a non-judgmental or, we tend to profile people without profiling them. Go with an open mind and see what are the symptoms they have, list them, and what is worst and what you want to get better first, because you can't handle all of these, and start with that. Find a corner to unravel the ball. And look at the investigations done previously and try to make a positive diagnosis or differential diagnosis. I know in the books we were asked to, this kind of patients, we were asked to tell them that we accept that their pain or the problem is real. But if you try to tell it to the patient, because we never tell such a thing to patients with real problems like cancer or stroke or something, I know you are really suffering, your problem is real, like that. But we have to show it by asking about the symptoms and other components, because we show an interest only, we ask these questions. So if you do that, the patients will develop faith in us and the system. And also remember that these patients, as I told you by the example of this beetle, dung beetle, our human beings also, with a slight change in the environment, we react to it and it changes our behavior. And that those behaviors will change our thoughts and the personality. So the same way it can happen other way around also. For example, a small thing like a computer chair which is not compatible with the desk. If you have to look at the computer like this, you have to tilt your head, your jaw will drop, and you are staring at it for hours, and you can't stay open mouthed like that, so you have to close your mouth, and all these muscles, they get fatigued, the neck muscles, and you get a headache. And because of the headache, you tend to sleep or keep certain unnecessary pillows when you're sleeping. So your behavior changes, and you think, oh, these pains are there, so you become irritable and you try to think whether this is, oh, my grandfather also had a stroke. Is this the first sign of the stroke? So like that, this irritable person at home is not very friendly with the family members or the colleagues. So they also try to get away from him. So then the personality slowly changes. So that is what happens to these chronic patients. So to stop that, we have to identify them early and to do necessary changes to make them better. So the first thing is to take some time to explore. Tell them, you had these symptoms for a while, so let me also have a little bit of time to understand you and your symptoms. So listen and observe. Don't panic and give placebo treatment. Don't give something for the patient. You can do some general measures like advice on stress management, sleep and sleep hygiene, and general health advices all these speakers told you, right? And the other comorbidities. And then once you finish with that, and if you want more investigations, please do them and communicate with the patients and say it is unlikely for you to get a stroke at this time or a heart attack or a cancer. This is very important because they want that particular word to come out sometimes. And list the contributory factors and try to help with the patient, to write a symptom diary, symptoms and what are the things the patient thinks contributed to that particular symptom. And look at the supportive things and strengthen them. And if necessary, you can liaise with the physiotherapy team or the psychiatrist or whatever the team you think will help this patient, but being the key person for this patient, because we should not, hand over the patients, but give shared care for these patients. And lastly, I want to tell, when you look at multiple somatic symptoms, the first thing, take home message is, don't think, oh, these are troublesome people, never get better, kind of attitude. Yes, these are people who we need to help, and sometimes they belong to this picture, the Mexican fish they call it Mexican walking fish, but it's a salamander, right? That is there are maybe rare kind of things like depression and the category which I mentioned to you earlier, multiple sclerosis. Or the other one is, it's the complicates the picture. It is not one, but the two animals. A crane is chasing a kind of a bull. This was taken from Rajasthan, India, right? So there may be things superimposing one after the other, the second kind of thing. So if you identify the second thing, that is the one which is difficult. Slowly take your time, tell it to the patient, take shared responsibility and help the patient to understand himself and to have a quality life despite of having some symptoms. So I hope you got some idea about how to manage patients with multiple somatic symptoms, and thank you very much for your patient listening. Thank you.
Thank you, Harshini, for that very clear presentation. So we'll leave the questions at the end. And I would like to invite our next speaker, Dr. Madhuvanti Vidyarachchi. She is the consultant physician at the toxicology unit of the Peradeniya Teaching Hospital. She has keen interest in NCDs and tropical infectious disease and toxicology. She's a member of the specialty board in medical toxicology who works with us. Over to you, Madhuvanti, for the presentation.
Good afternoon, ladies and gentlemen. First of all, let me thank the President and the Council for giving me an opportunity to speak at this prestigious forum. So today my topic is clinical approach to poisonings of unknown origin. As specialist physician in internal medicine, we encounter these kind of patients daily in ETUs and in the ward. So, it's important to arrive at a diagnosis taking into the consideration the clinical clues uh, and investigations and unravel these toxicological conundrums. Sorry. Thanks. So let's move on to our case number 1. We have got an 18-year-old previously healthy girl who has admitted with a history of vomiting and abdominal pain after dispute with her parents 2 hours back. And her parents found empty bottles which contained her grandmother's medication prescribed for 3 months near her bed. And this was the case scenario during the COVID lockdown period where we have actually posted clinic medicine for 2 to 3 months. So on examination, she was dehydrated. Her GCS was 14 out of 15. And you can see that she was little tachycardic and blood pressure little on the low side. Her clinical examination was otherwise unremarkable except for few coarse crackles in her right lung. So how are you going to address this problem? What are the important aspects in the clinical history in a patient with ingestion of an unknown poison? It is important for us to know time at which the patient was seen last to guess the timing of the poisoning. And if there are any remaining tablets, poisons or blister packs, get them because it's important to know the names. Patients or relatives' clinic notes are important if the patient's relatives are living in the same household, and if there are suicidal notes, if any, and recent prescription notes of also importance. The labels of poison bottles and whether the patient has vomited before and the color of the contents of the vomitus is also important, as well as particles or tablets. And time is important for the patient to reach the hospital. So to decide whether we are to give the gastric lavage and an antidote and activated charcoal for that matter during 2 hours time. So it is important the time taken for the patient to reach the hospital. And if the patient was transferred from a peripheral hospital, it is important to know what was done at the peripheral hospital. So what are the investigations which are essential in every poison patient? So if you do an arterial blood gas at the bedside, it will yield so much of information that you can almost arrive at a diagnosis. And random blood sugar is very important. So do the electrolytes as well as calcium and magnesium if possible, as well as other basic investigations. So in our patient, the APG showed a pH of 7.08 and the bicarbonate was 6 millimoles per liter. And you can see that so there was a base excess of minus 24.4 and the lactate was more than 15 millimoles per liter. And can you see that there's an anion gap of 33 millimoles per liter with low blood sugar levels. Others are of course normal with a slight elevation of serum creatinine. So how do you interpret this blood gas analysis? It's a high anion gap metabolic acidosis as you have seen in the previous slide. So let's talk about this electrical neutrality in the body. Usually the cations equals to the anions in the body to maintain the law of equality. So as you can see, the number of cations equal to the number of anions. That means the positive charge are cations and the negative charges are the anions. So basically sodium and potassium consist of most of the cations in the body, and there's a part unmeasured cations as well, which consist of calcium, magnesium and proteins. And in the other side you can see the chloride and bicarbonate, which consist a bigger proportion of negatively charged anions, and there's this unmeasured anions also. As you can see, there's a difference between unmeasured cations and the unmeasured anions. So that is called the anion gap. So this is the equation, measured cations, unmeasured cations equals measured anions plus the unmeasured anions. So this anion gap can be calculated by reducing measured anions from the measured cations basically. So this is the anion gap. So anion gap consists of sodium plus potassium minus bicarbonate plus chloride. Because the potassium component is really small, we just try to ignore that and we take anion gap as the sodium minus bicarbonate plus chloride, and the normal range is 8 to 12 milliequivalents per liter. So basically this is this is what you call HAGMA, high anion gap metabolic acidosis. This is what you see normally, and here in high anion gap metabolic acidosis, what has happened? The bicarbonate has actually gone down and the chloride is remaining in normal proportion, and you can see there's increase of unmeasured anions, increase in the anion gap here. And you have to remember, albumin is the single largest source of unmeasured anion in the healthy population. So failure to correct for a low albumin would falsely depress the anion gap, and it can mask the presence of a high anion gap metabolic acidosis. So you need to correct it with the calculation here. So what are the causes of HAGMA or high anion gap metabolic acidosis? So you can see, there are so many mnemonics for that. So Goldmark is one of those. I just want you to sort of concentrate on this O. This is actually chronic acetaminophen, which can generate 5-oxoproline, and again it's a cause for HAGMA. So remember that, and you have these other things which we usually know. And this is another mnemonic, cat mud piles. You can see, the methanol, diabetic ketoacidosis, and you can see the iron and isoniazid also, which you might not remember easily. And there are 1001 causes for HAGMA, but remember metformin is also here. So going back to our clinical scenario, you can remember that she had low RBS also. So what are the possible medications that she would have consumed? Can it be metformin and sulfonylurea, metformin, or can it be salicylate? So let's take one by one. So what are the possible other causes that can cause similar picture? Other substances. If the patient has taken ethylene glycol, brake oil or methanol, those things also can produce a similar picture. So what other investigation that you do to confirm such cases? So in this scenario, you need to measure the osmolar gap. So measured osmolarity minus the calculated osmolarity will give you the osmolar gap. And you need to screen for an elevated osmolar gap by doing ethanol, methanol and ethylene glycol levels. Of course, some of these are not available in our settings, but you can do a urine oxalate crystal, which is actually a very simple investigation. So even in the best of centers, more specific tests like methanol, ethylene glycol and usually require several days to come. So it is important to calculate the osmolar gap, and the normal value for the osmolar gap is generally set to less than or equal to 10 milliequivalents per liter. So this is how you calculate the osmolar gap. I'm not going to go into details, but if the gap is more than 20 milliosmoles per liter, that indicates the presence of a toxic alcohol. Now let's go back to the metformin toxicity. So what are the manifestations of metformin toxicity? It can cause nausea, vomiting, abdominal pain, myalgia, altered mental status, and cardiovascular instability with renal impairment is also seen. Can metformin overdose present with hypoglycemia? Usually you know that metformin will not cause hypoglycemia, but if it is complicated with metformin associated lactic acidosis, it can cause hypoglycemia also. And hypoglycemia is less seen in these scenarios. Why not salicylate poisoning? Usually, the respiratory alkalosis is predominantly seen in these adults due to the stimulation of the CNS respiratory center. But in small children, remember that it is again a possibility. And synchronism, tinnitus, tachycardia, hyperventilation, and hypothermia can be seen in salicylate poisoning, and you have to look for these. Again, then a question comes, can salicylate toxicity present with hypoglycemia? Yes, clinical hypoglycemia is possible even when the serum glucose levels normal. And CNS hypoglycemia may occur even when the blood glucose levels are within the reference range. That happens due to discordance between the plasma and CSF glucose. So the treatment of phlegma is the correction of the underlying cause. In mild to moderate acidosis, treatment should be limited to supportive measures including intravenous fluids and respiratory support. Now, sometimes you have to do the alkalization therapy, and it has to be reserved for those individuals with severe acidosis. pH should be less than 7.1. In the case of diabetic ketoacidosis, as you all know, this value is even lower, because unnecessarily giving bicarbonate is not good. It will increase the intracellular acidosis. So, taking into consideration all these facts, what is the most probable diagnosis in our patient? So, MALA is a possibility, metformin associated lactic acidosis, because we have gone into the history to rule out whether there is any combination therapy, like metformin and other sulfonylurea. She denied. So, this was the diagnosis. So, how are we going to manage our patient? So, again, ABCD approach. So, initial treatment options, now the patient presented within 2 hours, so gastric lavage and activated charcoal should have been given, and IV access and correct hypoglycemias, and you need to give the fluid boluses and consider giving maintenance, and you can consider bicarbonate loading dose. The pH is actually less than 7.1, so you can start a bicarbonate infusion also. What other investigations that you should have done in this patient, and you need to exclude any sepsis, do a chest x-ray, and if possible toxicological screening, and urine HCG also you shouldn't forget in this patient who is in the reproductive age group. And what are the management options available for MALA? So you need to give the supportive care and enhance the elimination, which are the mainstay of treatment. Give IV fluids, inotropes, bicarbonate, mechanical ventilation and cardiovascular support, correct hypoglycemia, and if there's any other electrolyte imbalances, correct them. And hemodialysis is in selected cases to treat the underlying conditions is also important. Dialysis is actually successful in patients with MALA in both acute and chronic overdose, but you might think when to start the dialysis. So, it's a dilemma still, but usual indications for this actually are the following things. There are significant comorbidities. If the patient is critically ill, and if the pH is less than 7.1, and if there's failure of supportive care, renal insufficiency, and if there's fluid overload status, you need to consider giving hemodialysis. And hemodialysis will remove metformin from body and restores the acid-base balance. CRRT is considered more suitable for hemodynamically unstable patients, but it is the metformin clearance is less actually. And there's an entity called SLATE, sustained low efficiency dialysis with bicarbonate containing dialysate, which produces a higher clearance of metformin than continuous veno-venous hemofiltration or hemodiafiltration. There are studies done, references are written. So the conventional intermittent hemodialysis effect, though it is effectively clearing metformin, the plasma level increases at the end of the procedure because there's a redistribution from the intracellular compartment. So the SLED actually is useful because it gives a longer treatment session, and it also decreases the risk of rebound toxic range of drug plasma levels. And the use of the bicarbonate dialysate may increase the metformin clearance. And all survived patients with severe metformin poisoning actually showed clinical response only following hemodialysis. And It is evident that early initiation of hemodialysis reduces the morbidity and mortality. And there are few case studies which have tried HIAT, high insulin euglycemic therapy. This is an indication in calcium channel blocker and beta blocker overdoses. So it actually helped by reducing lactate, improving pH and patient's clinical condition, but more studies are needed for this. So the case number 2 is a 40-year-old man who was transferred from a local hospital with an ingestion of an unknown poison which has happened 12 hours back. He has a history of reduced urine output, shortness of breath, abdominal pain and vomiting. His GCS was okay and he was having a tachycardia, and abdominal examination did not reveal any organomegaly. He has low saturation, normal saturation. Bilateral lower zone crepitations were noted on lung auscultation. If you can see again, there's a pH of 7.08, bicarbonate again 13.8 with a base excess of -18. And you can see there's a osmolar gap of 20 and the anion gap is 32. And there's a slight elevation in the CRP with blood urea and creatinine elevation. So this has this was discussed earlier also, how to calculate the osmolar gap. So the compounds that can cause a similar clinical picture as we have described earlier, methanol, ethylene glycol containing compounds like brake oil is a possibility. So this is our diagnosis. So we have to suspect ethylene glycol intoxication in a patient with a pH less than 7.3, serum bicarbonate level less than 20, osmolar gap of more than 10, and if there is a presence of urine oxalate crystals. So this is the typical urine oxalate crystals. On the left side you can see that there is a typical back of the envelope picture, and less commonly you can see these needle shaped calcium oxalate crystals also. Just for the interest I have put this. The oxalic acid and glycolic acids are the breakdown metabolites of ethylene glycol with alcohol dehydrogenase. So these metabolites have longer half-life and give rise to toxic clinical features. Toxicity of the ethylene glycol is actually described in 3 phases. Early phase comprises of central nervous system effects up to 12 hours. Then cardiorespiratory phase is 12 to 24 hours, and 24 hours later the patient usually develops flank pain, oxalate crystalluria, oliguria and acute kidney injury. Now when the concentration of oxalate increases, there will be hypocalcemia. So you need to replace the calcium in that instance. So what are the treatment options available for ethylene glycol? Gastric decontamination, inhibit the metabolism, increase elimination. Vitamins are needed to reduce the complication because there are some pathways which involve thiamine and folic acid also. The correction of metabolic acidosis in the initial stages needs to be done with caution. You need to look for hypocalcemia and hypernatremia. So antidote is the Formoterol, that is the FDA approved antidote. It inhibits alcohol dehydrogenase, but it's very expensive and it's not available in Sri Lanka. But most of the patients benefit from IV or oral ethyl alcohol, and both these competitively inhibit alcohol dehydrogenase enzyme, and it is effective up to 6 hours. But when you are giving ethyl alcohol, you need to be carefully monitoring the patient in the HDU. And if possible, do the ethanol levels also. HT can eliminate ethylene glycol more rapidly compared to Formoterol, and when the patient presents late with acidosis, hemodialysis can be used to eliminate the toxic substances. So in summary, in an unknown poisoning, detailed history and performing bedside investigations including ABG is important. Metformin-associated lactic acidosis is suspected with a low blood pH and high serum lactate levels and high anion gap metabolic acidosis. The treatment with sustained low efficiency dialysis SLED has proven benefits. Acidosis, low bicarbonate and high osmolar gap with urine oxalate crystals support the diagnosis of ethylene glycol intoxication. Treatment with oral ethyl alcohol, low-cost antidote has shown survival benefits. Thank you.
Right. Okay. Thank you very much, Dr. Hettiarachchi, right on time. So we have some time for questions. Could you please join us on the stage, both our speakers? So if there are any questions, we have some 5 minutes to answer any questions. So I have one question from Dr. Hettiarachchi. So this question won't be on an unknown poisoning, but rather the well-known poisoning of paracetamol. So in the case of paracetamol poisoning, the NAC regime will be finished in about 24 hours. So say the patient is still symptomatic and the liver functions are still deranged. For how long would you continue the NAC and in which dose? And in the situation where you don't have NAC, what are the other possible alternatives you have?
Actually, when the patient is not responding, you can always continue with the NAC infusion, and until such time the INR comes to 1.02, you can continue NAC infusion. And in certain instances, you can use the high dose also, 150 milliliters per kg, like in a large dose when you use it. Usually the levels come down quickly, and we have been using it, and with that is effective actually. For alternative treatment for NAC is actually we have NAC, and we use NAC because it's the kind of a proven thing, and the oral methionine is not that effective in that situation, so we have to use NAC. There are indications for oral methionine where usually if the patient does not have a higher elevation of liver function test, we can still use oral methionine. I think Prof. Shaluka will also be able to give some information regarding that. So that is how we manage paracetamol toxicity.
Thank you. We have 2.5 minutes for any other questions.
Let me ask a question from Dr. Harshini. In this normal physician practice, we see small doses of antidepressants being prescribed. Most of the prescriptions we see that because I think the clinician probably thinks there is a somatic component to the physical illness. How would you see that? Because sometimes these antidepressants have a lot of side effects. But despite that, among normal prescriptions, we commonly see antidepressants.
Thank you very much. Yes, we see these antidepressants usually, but if you prescribe it for a reason, I think it's okay. Especially I have seen tricyclic antidepressants, if there's for a pain or something, for a pain syndrome, neuropathic, it's okay. Or depression, then again it's okay, or anxiety. But without properly assessing the patient, just because the patient is having multiple somatic symptoms, I think it's not advisable just to give antidepressants or anxiolytics for that matter, especially since you mentioned this, I would like to say alprazolam. There are a lot of people who are addicted to alprazolam because of this free use. It's as a kind of can't stop it. So therefore, if there's a reason, please give. That's very good. But if there's no reason, just because without analyzing as a multiple somatic symptoms, okay, we'll get rid of the patient, giving antidepressants, that is not the correct thing. Hope I answered your question. Thank you.
So we have time for one more question. Just a question from one of our virtual participants. This is for Dr. Hettiarachchi. How do you differentiate Prinzhorn poisoning and ethylene glycol poisoning?
Actually, we haven't come across many Prinzhorn poisonings, and if anybody else in the audience can explain, Prinzhorn poisoning, I think.
It's a different poison. Prinzhorn is a detergent that is used in the south, especially. It has actually oxalic acid and potassium permanganate. So generally, it also gives rise to lactic acidosis, as you mentioned. But the presentations are different. One of the main presentations is methemoglobinemia. So there be cyanosis and other features of methemoglobinemia due to potassium permanganate. Of course, there is acidosis because of the oxalic acid.
Right, thank you, sir. And with the interest of time in mind, we'll wind up here. So I invite Professor Shaluka Jayamano to hand over the certificates of participation. Dr. Veerasuriya, thank you for being with us. You will receive your certificate by email.
Thank you.
First, Dr. Harshini Rajapaksa. And Dr. Madhuvanti Hettiarachchi, please. Right, thank you very much, and that concludes the symposium number 4. So we'll break up for lunch. Please be here by 2 o'clock for the next session. Thank you very much.